So very good evening to you all, and I hope you all are doing well. Today we are going to discuss a very important topic, all about checkpoint inhibitor endocrinopathy. Again, it's a very important topic, commonly occurring nowadays in the specialty certificate exam. Very useful in clinical practice, with more and more checkpoint inhibitors being used by oncologists and hematologists, and across all specialty exams. So let's start right away. So just to start with, a special thanks to Dr. Waleed Al Zain. He's working as a consultant in Kingdom of Saudi Arabia. He's an integral part of the endocrine department there in the Armed Forces Hospital in Kingdom of Saudi Arabia. He has helped to contribute some of the cases which we are going to do via a case-based approach to look in detail about the checkpoint inhibitor endocrinopathy. So let's start by looking at what are these checkpoint inhibitors, which we should know about in clinical practice as well as for the exams. So the first group is the PD-1 and the PD-L1 inhibitors. They are a group of checkpoint inhibitors. Of course, they are anti-cancer drugs. They are specifically called that way. It's called the program death ligand 1, PDL1, or the program cell death protein 1 inhibitors. And as I mentioned, that these immune checkpoint inhibitors, they block the proteins present on the surface of the cells. So they are emerging as a frontline treatment for several types of cancer, increasingly used by the hematologists and oncologists. And that's why it is extremely important for us as endocrinologists or physicians to be aware of the possible side effects which these can cause. And of course, if we are considering endocrine perspective, then we should look at the endocrine side effects which these checkpoint inhibitors can cause. So these are the approved PD-1, PD-L1 inhibitors up to 2021. As you can see, I mentioned this because it's important to have a quick remembrance of the names as well among these categories. Nivolumab, pembrolizumab, these two commonly and we encounter in the exams in the questions. The others less commonly, but as and when the trends are changing with new and new checkpoint inhibitors coming in, I'm sure in the subsequent exams we can also come across the other name, which is atezolizumab, evolumab, durvalumab, semiplimab, dostarlimab. Okay, so these are the approved PD-1, PD-L1 inhibitors. And as I mentioned, the two commonly occurring in the exams is the nivolumab and pembrolizumab. And they are commonly used for treatment of cancers like melanoma, Hodgkin's, non-small cell lung cancer. Nivolumab is also used for the treatment of some kidney cancers and head and neck cancers. And pembrolizumab is used for cancers of urinary tract. I wanted you all to familiarize yourself with the names, because when you come across these names in the questions, you should be knowing what category of checkpoint inhibitor it is. It is a PD-1, PD-L1, just to get a more better idea, because some of the endocrine side effects are more common in one category compared to the other. So what's the next category which we should know? It is the CTLA4 inhibitors, also called cytotoxic T lymphocyte associated protein 4 inhibitors. And the most commonly encountered in the exams is the ipilimumab. Okay, it is a checkpoint inhibitor drug that blocks CTLA4. It's used in the treatment of advanced melanoma and advanced renal cell cancer. The other CTLA4 inhibitor which we should be aware of is tremelimumab. And this is still in the process of approval for certain types of cancers. But the commonly appearing in the exam so far is ipilimumab. So what are the common endocrine immune-related adverse events, which they call it? Okay, it's also referred to at some time as IRAE, or immune-related adverse events. Commonly, when we can encounter thyroid problems, hypothyroidism, thyroiditis, there can be pituitary issues, especially with ipilimumab. As I mentioned, it's rare with PD-1 inhibitors. Hypophysitis can occur, hypopituitarism can occur. Other rare side effects can also happen, like adrenal insufficiency, type 1 diabetes, decay, And unlike most other immune-related toxicities, endocrine adverse events frequently do not resolve and result in permanent hormone deficiency. So this is very important to keep in mind that usually we encounter endocrine adverse events which will result in a permanent hormone deficiency, not like the other systemic events which are caused by the checkpoint inhibitors. On that note, let's start with case number 1. So here we have a 52-year-old man has been undergoing treatment for melanoma with immune checkpoint inhibitor nivolumab. So again, moment we get this name, it should come to mind. It is belonging to the first class, which is can be PD1, PDL1 class of inhibitors. So at least we should know that category. Even if you don't remember whether it's PD1 or PDL1, it doesn't matter. But at least we should know that category of the checkpoint inhibitor for the last 3 months. He noted progressive fatigue as well as dry skin and hair. He has no history of thyroid disease and no family history of autoimmune disease. On lab evaluation, his serum TSH is elevated, is clearly hypothyroid. TSH is 15 and free T4 is low, so clearly overt hypothyroidism. And his anti-TPO antibodies are positive at 28. So which of the following is the most likely etiology for this patient's hypothyroidism? Is it destruction of the thyroid gland by chemotherapy? Is it trigger of autoimmune hypothyroidism? Is it central suppression of TSH? Or is it hypophysitis? So I think the last two options can be easily ruled out because the TSH is elevated. Amongst the other two, of course, we did not see any phase of hyperthyroidism. There was a direct onset of hypothyroidism. So the correct answer is B. So there was a trigger of autoimmune hypothyroidism. And what triggered it is the checkpoint inhibitor nivolumab. So cancer treatment is associated with wide range of endocrine disorders. So here we are talking about checkpoint inhibitors. And thyroid is by far the most commonly affected. Central suppression of TSH can be seen with some other drugs like retinoids, like xenoids, but of course that was not there in the question. The immune checkpoint inhibitors, as we saw in our question, are associated with endocrinopathies, can cause subacute thyroiditis, but that was not the picture in this scenario. It has caused a triggering of the autoimmune thyroid disease, which was our scenario. And of course, there was no hypophysitis because the TSH was high, not low in this scenario. Given the elevation of TSH in the presence of low T4, hypophysitis is unlikely. That is what I mentioned. The elevation of anti-TPO, although modest, suggests triggering of autoimmune hypothyroidism. And of course, the treatment in this scenario will be levothyroxine, straightforward. So let's talk about primary hypothyroidism in context of a checkpoint inhibitor. Okay, so workup and evaluation, we should always try to do a baseline TSH. This is very important, and with an option of including FT4 if possible. And this should be checked in every 4 to 6 weeks as a part of routine clinical monitoring on patients with immune checkpoint inhibitor therapy. Why? Because there is so much fluctuations happening in the thyroid functions. One of the scenarios we just now saw. And that's what's important to get these tests done at the baseline, plus also for every 4 to 6 weeks while the patient is on the immune checkpoint inhibitor therapy. What is mentioned further is low TSH with a low free T4 is consistent with central hypothyroidism. So that also we should keep into consideration. Even that can happen. In our scenario, it is a primary hypothyroidism, but even we can encounter central hypothyroidism in which we can have a low TSH or a low FT4. About hypothyroidism, it can also occur after a phase of thyrotoxicosis, what we encountered in thyroiditis. So there'll be hyperthyroidism followed by hypothyroidism. So even the checkpoint inhibitors can trigger that as phenomenon as well. So let's look now at hypothyroidism more in detail from a endocrine and an oncology perspective. So basically, as an oncologist, they usually grade the degree of the individual endocrine complications as well into grade 1, grade 2, grade 3, and grade 4. So the grade 1 in context of endocrine, immune checkpoint inhibitors and onset of hypothyroidism is if the TSH is more than 4.5 and less than 10, and the patient is asymptomatic. So in this scenario, it's graded as grade 1. And in this scenario, we should continue the checkpoint inhibitors with monitoring of the TSH with an option to do a free T4 and monitoring every 4 to 6 weeks as a part of routine. In the scenario where it is grade 2, which is moderate symptoms, patient is still able to perform activities of daily living. TSH is persistently more than 10. Persistently, when they say, means at least we have taken 2 samples, which are more than 10, at least 4 to 6 weeks apart. In this scenario also, the patient can be easily treated with thyroxine. So we may very well continue the IC-PI, which is the checkpoint inhibitors, until the symptoms resolve to baseline. There is another option to hold it. But usually in this scenario also, in majority of the case scenarios, this is very easily manageable with just adding thyroxine. So in majority of the cases, we continue in this scenario. Prescribe thyroid hormone supplementation in symptomatic patients with any degree of TSH elevation. This is important. Or if we encounter an asymptomatic patient, then we need at least 2 TSH about 10, measured 4 weeks apart. Then monitor TSH every 6 to 8 weeks while titrating the hormone replacement to goal of TSH within the reference range. This is what we do for all our hypothyroid patients. And FT4 can be used to help interpret ongoing abnormal TSH levels on therapy, as TSH may take longer time to normalize. These are concepts which we know already when we are treating a standard hypothyroid patient. Once adequately treated, we can do a repeat testing every 6 to 12 months. What about if it is grade 3 or 4? Now, in this scenario of hypothyroidism, there are severe symptoms, medically significant or life-threatening consequences, unable to perform activities of daily living. Now, in this scenario, clearly we need to hold off the immune checkpoint inhibitors until the symptoms resolve. Again, endocrine consultation, patient may need a hospital admission if there is a hypothyroid crisis like a mixed edema, coma, bradycardia, hypothermia, altered mental status. Patient may need inpatient admission for IV levothyroxine for treating the mixed edema. If there is uncertainty about whether primary or central hypothyroidism is present, hydrocortisone should be given first before thyroid hormone is initiated. We know all these concepts already. Mixed edema coma is life-threatening and will require high level of care. Once stabilized, thyroid supplementation like in grade 2. General principles, as we all know, if the patient is without risk factors, less than 70, not frail, without cardiac disease or multiple comorbidities, full displacement of thyroxine we start, which is 1.6 microgram per kg per day. If we have an elderly patient, frail patient, multiple comorbidities, cardiac disease, we always start a lower dose of thyroxine between 25 to 50 and titrate up. And then we basically take into consideration the FT4 levels as well, titrate the dose of thyroxine, and then monitor the thyroid function test. Okay, so rest of the things are almost similar how we manage a normal hypothyroid patient. So a little bit more about hypothyroidism in context of the checkpoint inhibitors. Sometimes there may be a phase of hyper followed by hypo, which we call it thyroiditis, that can be precipitated by the checkpoint inhibitors as well. There is a very high incidence of subclinical hypothyroidism, which can recover. Thyroxine will definitely give if there is a low T4 or if the TSH is more than 10 on 2 occasions. And as I also mentioned in the previous slide, symptomatic patient as well. We should always keep a high index of suspicion for secondary hypothyroidism, especially if the patient has received a CTLA4 inhibitor, which is that ipilimumab, which we saw that. But in our patient here, he was getting nivolumab. So usually it will be more of a primary hypothyroidism. Secondary hypothyroidism, if the question is having mention of a CTLA4 inhibitor, immediately start thinking in that regards. Let's go to case number 2. A patient is woman in her 60s. She's on nivolumab therapy, again nivolumab monotherapy. After 6 cycles, she develops anxiety, palpitations, diarrhea. Her T4 is very high, 34. Her TSH is fully suppressed. So the free view of this particular lecture has ended. For access to this full lecture session, please subscribe to my lecture series, which is total of 60 lectures till date. These will be provided access to via paid subscription plan, and all the paid subscribers will be given a lifetime access to all my existing 60 videos lectures, which are already on the YouTube channel, plus all the upcoming new videos. So whatever lectures or sessions I'll be doing in coming weeks, months, and years, all of them will be given access to in the same subscription plan.
So for the full subscription details, please email me on mazzyrules@gmail.com or WhatsApp me on 009715574344794 and have the same number on the Telegram app as well. Just to give a brief overview of the full lecture series, so it includes different topics across diabetes and endocrinology. For diabetes itself is around 19 lectures which I've done across different topics which are useful for the exams as well as for the clinical endocrinology practice. In terms of high yield topics for specialty exam and European board exam, there are around 9 sessions which have covered all the previous exam recalls as well as all the high yield topics and themes which are frequently encountered in the specialty exams and the European board exams. In terms of thyroid, apart from the thyroid cancer guidelines, which were recently published, plus there are other sessions on different topics related to thyroid across the spectrum of thyroid disease. In terms of adrenal as well, covering all the important topics or sessions which are frequently encountered in exams and in clinical practice. There are two very good sessions on lab endocrinology by Dr. Velmurugan, very helpful for those preparing for DM endo or DNB endocrinology as well. In terms of pituitary also have covered all the important sessions on all the important topics which are frequently encountered in clinical practice and the exams. There are a few sessions on the inherited endocrine syndromes as well. Very important sessions on reproductive endocrinology, about congenital adrenal hyperplasia, gynecomastia, hirsutism, PCOS, diagnosis, evaluation, management. There is a sessions on calcium and bone metabolism, on familial lipid disorders, and sessions on pediatric endocrinology as well. So just to let you know that there are many more sessions coming up, and as I mentioned, that in the same subscription plan or same subscription fee, you will be provided access to all my existing 60 lectures plus all my forthcoming lectures. So thank you very much for subscribing. Thank you very much for supporting.